Good morning and welcome to Ask the Experts. Hopefully you can hear us okay. We're excited to be here and finally air this presentation. My name is Kimberly Mann. I'm one of the community liaisons at Hospice of Southern Maine. And this presentation is brought to you by our community education series, Ask the Experts. And today our expert guest, who we are so fortunate to have on staff, is Dr. Fernando Moreno. And he has been our medical director here since 2017, we were saying, and just a wealth of resources and knowledge. Definitely so happy that you are here today. Thank you. And he is going to be sharing a presentation on dementia and Alzheimer's and how hospice can help these diseases. Am I saying that right?
That's perfect. Thank you, Kim.
So because it's a really important topic, we want to get right into your presentation. And we will say that the few questions that were submitted, he's woven answers into his presentation. But please take advantage of the chat box or the Q&A to submit questions as you're thinking, and we'll read them at the end of the presentation and go over any. So do take advantage of that. So welcome and thank you.
Great. Thank you so much, Kim. I really appreciate it. And thank you, everybody, for joining us this morning. It looks like we have some great participation. So just really happy that all of you are taking the time to come and learn about a really important topic. Let's see, who will be advancing my slides? Am I able to do it?
Kim will.
Kim, all right. Go to the next slide. So, thank you. Yeah, so just to start, I have no disclosures to report. I do serve as the medical director for Hospice of Southern Maine, and part of my role is to provide education not only to the community, but various students and other learners who come through. This talk today was adopted from a presentation that was given by Dr. Sarah Halen and Heidi Weirman, who are two geriatricians in the community and have been really great advocates of palliative care and hospice and help to oversee the training of our fellows each year. So a little bit about our presentation today. We're going to talk a little bit about the types of dementia. The title slide does talk specifically about Alzheimer's disease, but we're going to open that up to talk about the other types of dementia as well. Alzheimer's is the most common. We'll talk a little bit about sort of things to consider when somebody is considering a dementia diagnosis. Talk a little bit about the various stages of dementia. This is really important about to help understand sort of when hospice becomes appropriate and why. Dementia is a condition that is notorious for being a very long condition. People can live with dementia for many years. So at what point hospice becomes appropriate is something worth spending some time in. We'll talk a little bit about some of the things that clinicians might do to help diagnose or identify when somebody might be having a cognitive impairment. We'll talk a little bit about some of the treatments and things that are out there, more specifically what hospice does when somebody is on service with dementia with us. So try to focus a little bit more on what hospice can do. So to start with, we'll talk a little bit about what dementia is. Is it the same as Alzheimer's? When we say the word dementia or cognitive impairment or delirium, is this all the same thing? Is this just part of getting older? I meet patients every day who are approaching their later years in life and will make comments to me like, well, I'm just old. Of course I'm forgetful. It should be expected. So we'll talk a little bit about some of the things that help to distinguish sort of normal aging from some more concerning cognitive impairments. You got an extra slide that I don't, so it's all right. So when we're first considering that somebody might have dementia, you need to consider what else might be going on, and this is part of what your physician and other clinicians are helping to do. There are lots of things that could really mimic depression, so it's really important that a good history and physical will be obtained to really help sort of pin down that diagnosis. It takes time to get a diagnosis. Often it occurs over a time period when clinicians and family members have the opportunity to observe patterns and behaviors over time. Oh, now I see what's happening. This is a live slide. So dementia can really be thought of as more of a bucket. There are various more specific types of dementia that exist. Somebody may say or may be diagnosed with Alzheimer's dementia or Lewy body dementia. You might hear of conditions such as frontotemporal or mixed dementia. Many of these have very similar clinical manifestations. There can be a lot of overlap, and they don't always necessarily distinguish themselves from one from the other quite well. But dementia, again, is more of a larger sort of umbrella term that encompasses many of these various specific diagnoses. It would be similar to saying, or using the word cancer. Cancer is a very sort of general diagnosis, but often we talk about what specific types of cancer people have. There's a difference between lung cancer and breast cancer, for example. So when somebody says dementia, they may be referring to a number of different things. So as I mentioned before, sort of history and physical are really key to helping determine whether somebody has developed dementia. And I'm going to pause here to introduce the term cognitive impairment, because this is something that now is being more widely considered. Dementia has been sort of out there for a long time. Again, there's a lot of sort of misunderstandings about what dementia means, what it encompasses. And cognitive impairment is a term that's now being used to more appropriately describe and categorize these buckets of conditions, again, which tend to have a lot of overlap. The duration of symptoms, sort of how things evolved over what time, is really important. Again, medical history is really important. There are various medical conditions. Somebody's thyroid, for example, not being treated appropriately can mimic and can manifest similarly to how dementia might appear. Family history is very important. Reviewing patients' medication history, substance use or histories of substance use. And function is all in caps, and it's underlined there because this is really sort of the heart of understanding and diagnosing cognitive impairments. What people tell you, what's happening, family members who come to the appointment and share stories about things that they're seeing. Geez, a year ago, mom was able to drive to the store independently, go shopping on her own, but she's having some trouble doing that. She got lost recently, or is having more difficulty managing grocery lists and shopping and handling budgets and so forth. So it's these stories and how families start to identify, or how loved ones start to identify things that just don't seem right over time, that help raise the suspicion that one might have dementia. Sorry, just waiting to advance the slide. All right, great. So dementia, this comes from the geriatrics literature, and the definition that helps make sense of what dementia is that this is an acquired syndrome. Again, it's not a specific diagnosis, but a syndrome. It might consist of a variety of diagnoses that tends to result from the decline in sort of multiple cognitive domains. And most importantly, these are deficits that start to arise that are significant enough to impact somebody's function. So people are noticing that it's impacting their ability to do day-to-day things. It's a syndrome. It's a general name for a group of diseases that might share similar signs and symptoms. And patients can behave very differently depending on types of dementia. Some might have manifestations that are primarily behavioral, so people aren't acting like themselves. They're impulsive. Maybe they're not as reserved as they used to be. People might be inappropriate at times, which might be new. Speech difficulties, people having difficulty finding words, difficulty with sort of language and recall, or being able to understand what people are telling them. The cognitive impairments often result from some sort of physical degeneration of the brain. One of the things that was most helpful to me when I was learning about dementia, just how to think about it, was to compare it to other organ systems where we have failure. Things like heart failure, for example, or renal failure. Those things make sense to people. Your heart's not working the way it used to work. It's starting to fail. Your kidneys are starting to fail. Someone once described cognitive impairments and dementia to me as a sort of brain failure. Our brain is an organ, and it certainly makes sense that over time it may not function the way that it used to, and it may reach a point where it's no longer able to sort of maintain and do some of the critical abilities. This change can happen slowly over time. Alzheimer's disease is one of those that's really sort of notorious for being a really slow and dwindling change over time. The average life expectancy from when somebody's diagnosed with Alzheimer's disease to death is approximately 10 years. However, retrospectively, when people look back and think about sort of patterns in history, there were signs and symptoms sort of leading up to that diagnosis that were often present for significant periods before that diagnosis. Some conditions, such as vascular dementia, can often manifest very quickly, sudden changes. Somebody has a stroke, for example, that's affected the circulation to their brain, and have gone from being a cognizant person, fully functional, to now perhaps having some cognitive deficits. So again, those things can happen quite suddenly as well. For the purposes of our talk, it's really important to highlight that cognitive impairments are terminal conditions. These are not conditions that improve over time. If anything, they tend to only get worse, both cognitively and functionally. People have tried various treatments that are out there, and the intentions of most of the treatments are not to reverse the process of dementia or worsening cognitive impairments, but really trying to preserve the function and the cognition that one has. So again, treatments are there to try to help prevent things from getting worse, but unfortunately, we're not at a place where we have the ability to do things to necessarily make dementia better. So I've talked about the term cognitive impairment, and again, this is something that's now being used by clinicians. We're trying to get away from the term dementia. It's too broad, it's not specific. Cognitive impairment really kind of speaks to what it is we're addressing, and it helps us to start to maybe sort of measure and put people into various severities of cognitive impairment. So mild cognitive impairment. So this is one where there's no impairment of function. Patients might notice that their memory is not what it used to be, that they're sort of forgetting things that used to be easy for them to remember. They're having trouble remembering people's names, for example. This doesn't necessarily mean that you have dementia or a cognitive impairment, or that you're likely to develop one over time. But it is potentially a risk factor. We see that patients who do have sort of a persistent mild cognitive impairment, about 10 to 15% of these people each year will become classified as having a more severe cognitive impairment. So it's really important early on when family members, or in my case, when patients are telling me that they're having difficulty with some of these things that used to not be an issue, that we're doing a full evaluation to look for reversible causes, other things that might be contributing, but really sort of monitoring over time to see how these evolve really helps to make the diagnosis. Many people have heard the term delirium, and I know for me early on that these were often used interchangeably, but they're very different conditions. Dementia is not delirium. Delirium is a sudden change in cognition. So this is somebody who is, functioning well, gets a pneumonia, for example, needs to be admitted to the hospital, and while they're there, they're not behaving like themselves. Their level of alertness might vary. Their sort of thought process might not be what it normally is. They might be disorganized. Their sleep-wake cycles, for example, can be disrupted. These things are often precipitated by some sort of acute underlying medical condition. So you're ill, and that's why your brain is not functioning the way that it should. And so sometimes the things can sort of manifest and look very similar to some of the dementia conditions that we're discussing. Dementia, on the other hand, is a slower progression. It's not something that just appears overnight. The geriatricians in the hospital, often talk about how they can't diagnose dementia in the hospital. When somebody is present and they're dealing with an acute illness, you can't sort out and differentiate, is there sort of a more persistent and underlying cognitive impairment here? Or is this a delirium that's purely related to sort of this acute change? Again, there is some relation. While they're not the same, there do seem to be some associations. So patients who develop delirium when they're sick and in the hospital, and this might be the first time we sort of see that altered cognition, those people are at risk of developing dementia over time. And vice versa, people who have cognitive impairments who now become acutely ill are likely to also develop delirium as well. So they may have a baseline cognitive impairment, but when they're sick, those symptoms may be significantly worse. That does have the potential to improve. Again, if you are sort of treating the underlying sort of acute medical problem, very often people will sort of get back to where their baseline was. But often what we see, and one really important thing to note, is that when patients with cognitive impairments get sick, they never quite get back to exactly how they were before. Many family members will say, last year, things were okay. We were able to manage. We were able to visit a few times a week and help with grocery shopping and other things, and we were getting by. And then, dad was admitted to the hospital 3 times this year. He had COVID, then he fell, then he had a pneumonia after that. And each time he was just a little bit worse off. We were having to do more things for him. We were having to do more reminders. We're now worried about his ability to live alone and live safely. So again, we can see these things developing over time, but for people who have dementia, who have cognitive impairments, when they get sick, there's always the potential to make things a little bit worse. One of the things I struggle with on the palliative care team in the hospital is a lot of times we get blamed for not being able to get people back to how they were before. Somebody will come in with an acute illness, may need surgery, might need antibiotics for a period. We treat that condition, it gets better. They've sort of been improved and are able to be discharged from the hospital. And then family members will say, but they're not the same person they were before. They're not behaving the same way that they were before. They're not able to do some of the things that they used to. And many times people might attribute that to some sort of failure of the treatment team or failure of the hospital, and fail to recognize that instead that brains that are already sort of impaired and struggling have less reserve and less tolerance to be able to handle sort of new and acute illness. So that's a pattern we often see, is that patients with cognitive impairments might get a urinary tract infection, for example, that suddenly worsens their function going forward. And just one last thing on the prior slide is that they're often similar etiologies, meaning sort of similar sort of causes for how these conditions present. One example, when somebody's acutely ill in the hospital or in the intensive care unit, is blood pressure is sometimes difficult to manage. Patients with really severe infections often have drops in their blood pressure, so you're not getting good circulation to your brain. That can sort of temporarily affect how your brain is functioning. But people who sort of have those episodes over time, so various periods where you're not getting sufficient oxygen, could be various heart conditions, could be things like COPD or lung disease that affect your oxygen levels, over time can also impact your brain function. So again, an acute illness, you have pneumonia, it's treatable, but for a temporary period, you're not getting sufficient oxygen levels to your brain. Can sort of affect the brain similarly over time to people sort of who have those sort of repeated insults. It's important to note that the cognitive impairment and dementia is not the same as depression. There can be a lot of overlap. Depression is quite common. Certainly something that people struggle with is function changes, as various sort of major life changes as well. It can affect mood, it can affect how we're thinking, and it can manifest and look very, very similar to dementia. Differences one is potentially treatable. So patients who are receiving appropriate therapy, support, getting good rest, getting good exercise, good nutrition, perhaps medications to help manage their depression, can show some improvements over time. And dementia and cognitive impairments tend to not get better with treatment. It can be really hard to distinguish one from the other. Apathy can be a really sort of strong feature of both, and again, can be hard to sort one from the other. So again, so really detailed sort of histories about how symptoms started, how they manifested, was there a major life event that occurred at the time that these symptoms arose, how are they impacting function, patients' ability to perform their activities of daily living, will really help to distinguish the two. Cognitive impairments and dementia is not normal aging. I think this is one of the troubles we get into sometimes with delayed diagnoses is when people just say, well, it's just because I'm getting older. You know, it's not uncommon for people to have a little bit more difficulty with sort of multitasking. Some occasional forgetfulness is appropriate as we age. But these things should not be impacting our function, especially our activities of daily living, our ability to dress and select appropriate clothing, our ability to bathe and care for our bodies, our ability to eat and drink and select appropriate foods, to know how to swallow. Normal aging should not affect those things. Some of the risk factors for dementia, this is something that people are looking really hard at. There's a lot of money to be made if people can figure out the underlying causes and prevent people from getting demented. So a lot of interest in some of the things that could help. We know that there are certainly protective factors, things that can be done. People are looking at sort of various medications that could sometimes be helpful. Many of you have probably heard that doing a crossword puzzle on a regular basis can be really helpful to stimulate your brain. Things like Sudoku, staying active and engaged are really important. Cannot preach enough about the importance of physical activity for everyone from cradle to grave, regardless of your age. Physical activity has multiple benefits. Again, a lot of interest from our pharmaceutical industry and sort of medications, vitamins, and other things that may be potentially protective. So, we don't know for sure to what extent those things contribute, but we're looking at those. Things that definitely impact your risk factors are age. We see somebody in their 50s or 60s diagnosed with Alzheimer's disease that's classified differently. That's considered an early onset dementia. Most people are diagnosed much later in life. There does seem to be some family history, so knowing your family history, making sure your clinicians are aware is really important. There may be some genetic mutations. There are conditions such as Down syndrome that do cause Alzheimer's disease over time, tend to occur much younger in life. But the dementia pattern is very similar and very consistent with Alzheimer's disease. Other things that could be contributing, head trauma, the level of intellectual stimulation that somebody has been able to have over the course of their life, things like depression and other cardiovascular risk factors. Again, if you're not getting good blood flow and good circulation to your brain, your circulation is constantly bombarded with high levels of glucose because you have diabetes. All of these things can potentially cause your brain to get sicker over time. So Alzheimer's disease is one that people often hear about, or if you hear somebody has dementia, people often assume that means Alzheimer's disease. And for good reason. Over half of the people living with a cognitive impairment have Alzheimer's disease. It's a leading cause of death in the United States. Overall, it's the sixth leading cause. As you go up in years, as you can imagine, it becomes more frequent. But again, it's one specific type of dementia. So there's a lot of research into Alzheimer's disease and sort of what's happening, what causes this. This is just a brief diagram. I'm not going to get into too much of this, but people have heard about things like sort of amyloid plaques or just amyloid or neurofibrillary tangles. The thinking is that there are these various sort of proteins in the brain that over time can sort of break down, can cause these sort of clusters of plaques to develop in the brain that impair its normal function. These have been seen on autopsy in patients who have Alzheimer's disease, for example, but exactly sort of how these sort of form over time and what role they're playing. Some of these can be seen in healthier brains as well, so it's hard to know exactly what the underlying pathophysiology is. But we do know that these can be found in autopsy. So again, age, family history, genetics, cardiovascular disease. This is imaging of a brain of somebody who has advanced Alzheimer's disease, and on the left-hand side of the screen, as you can read, says healthy brain, and on the right is Alzheimer's disease. And this is one of the ways that we often will help to diagnose or support the diagnosis of dementia is by doing a CAT scan of somebody's head. Many times what you'll see is that the brain is failing and shrinking in size. That means that the spaces in between, or the ventricles, are often enlarged as the brain tissue itself sort of shrinks in size. So some of these changes are really sort of classic and can be seen on imaging. Alzheimer's disease was first described by Dr. Alois Alzheimer, and forgiveness if I said his first name incorrectly. And he really sort of categorized this illness to show that sort of memory loss was really sort of a key feature, in particular short-term memory loss. Many of you might have had experiences talking to somebody with Alzheimer's disease who has a really great sort of intact remote history. They can tell you about their childhood. They can tell you stories from the past. But could they tell you what they did an hour ago? Maybe more difficult. Often disruptions in awareness about time and space. So people aren't always aware of sort of where they are, may have some disorientation about what time it is, what time of the year, what time of the day, for example. Speech is often really impacted over time. In the end stages of dementia, and when patients start to become more appropriate for hospice, many people are nonverbal or sort of minimally verbal. They might speak, but it's more nonsensical. And sort of physical function might be affected as well. So apraxia, the ability to do things, to handle sort of complex motor tasks, so movements becoming affected as well. There are other types of dementia, as I've mentioned in the bucket diagram before, and these are probably some of the more common ones people hear. Vascular dementia. Vascular dementia is not a specific diagnosis. This is also a bit of an umbrella or a bucket, if you will. But it's various diseases that affect the circulatory system of the brain. So it could be atherosclerotic disease, just like your coronary disease are prone to developing atherosclerotic plaques and causing blockages. The same thing happens in your brain. This can cause sort of slower processing. Many patients with vascular dementia might sort of really struggle, but if you cue them, sometimes they're able to remember things. So different from Alzheimer's disease, where you can't really sort of jog those memories, and vascular dementia you often can. They can also impact sort of motor, so people can have tremors, they can have difficulty with gait and ambulation. They're mixed types. Again, people who have Alzheimer's disease often have many of the risk factors for vascular dementia. Somebody might have sort of classic Alzheimer's disease, but they have bad diabetes and bad heart disease. And so that's also sort of predisposing them to vascular insufficiency or vascular insults to their brain. Things like Lewy body dementia are more becoming more known. These are often categorized by more sort of hallucinations, people sort of seeing and hearing things that aren't there. Can sort of occur in spells, so maybe not more persistent, but sort of more episodes where patients become sort of acutely sort of confused. Frontotemporal dementia is one that seems to impact the frontal lobes of the brain, which are really important for our self-regulation and control. What we see sometimes in these patients is a great deal of disinhibition. Somebody who is very conservative throughout their whole life, who all of a sudden becomes very sexually inappropriate, for example, is something abnormal and is consistent with this particular type of dementia. So there are things that we can do to help sort of identify potential cognitive impairments, and some of these tools are really help to sort of capture patients or conditions that might be concerning, and then be able to evaluate them further. So these are simple screening tools. This is something your doctor might do in an office, and many of you probably had this done before, where doctor sits down with you and they're going to say, remember 3 words: apple, penny, and tree. And then they give you a task. They give you a sheet of paper and they say, draw a clock. Takes usually a couple minutes to do that. People draw the circle. You're asked to put the numbers on the clock in the appropriate place. We'll usually ask you to draw the hands on the clock at a specific time. So we'll say, please draw the hands for 10 past 10. And when you're finished doing that, we'll ask you to remember the 3 words. I'm not going to put you on the spot to ask if you remember. But it's really quite telling. Patients who can't remember those 3 words, and I'll be honest, I sometimes have a hard time remembering 3 words I asked a patient to remember. So by itself is not necessarily significant, but when you put these things together, somebody's having a hard time remembering these. or the first time you tell them the 3 words, they can't even repeat them back to you that first time. The numbers on the clock are distorted or disoriented. Again, these might be things that suggest that further testing is warranted. So again, a positive screen does not mean that somebody has dementia, only that you need further testing. Such testing might be cognitive. You might be sent to a neurologist or a geriatrician or neuropsychiatrist or a psychologist. There are various providers who are quite skilled and able to look at these. Some might depend on your sort of age and manifestation. I mentioned that there are sometimes medical causes that can be underlying and can manifest very similarly. So we do a variety of blood work and panels to evaluate different things, looking at your blood counts, your electrolytes, your thyroid gland, things like your vitamin B12 level, for example, can sometimes manifest cognitively when you're not at appropriate levels. Prior infectious history, things like syphilis, for example, can sometimes manifest later in life. HIV disease, which more people are living with these days, things like Lyme disease, toxins, heavy metals. So again, a variety of things that could be contributing and should be evaluated and should be ruled out before you diagnose somebody with dementia. Head imaging can be considered. I gave you some pictures to help you understand why that might be valuable. So what are some of the things that you can do? I already hinted on this one, being active, not just physical, but cognitively, socially, staying connected to a community, having a sense of purpose, having something to get up and do every day, enjoying your life, being active. Can't say enough for all of these things. And something that I think hospice does really well to continue to sort of highlight and make front and foremost in all of our patients' lives and care is really looking at ways to keep people engaged and active in life. Maintaining strong relationships with your providers, again, really identifying things early. I mentioned that many of the medications are not there to turn things around, but they can sometimes slow things down, and they're most effective when they're started early. So early identification is really key. Things to avoid, anything with a PM in it, I generally don't recommend. As people get old, a lot of these medications, Tylenol PM, Aleve PM, everything's got a PM in it. A lot of these contain more sort of sedative type medications that people use to help sleep. Maybe not the best idea for people who are struggling cognitively or might have some risk factors. Not clear why, but there does seem to be some association with these drugs. Again, we really want to do our best to help people maintain as much independence as possible. Again, treating any coexisting conditions. So if somebody has depression, if they have uncontrolled diabetes, treating those things will help help preserve as much of their cognitive status as possible. So a little about the stages. I talked a little bit about sort of early cognitive impairments and how the sort of life expectancy or time with dementia can be really, really variable. So some of the early signs and symptoms, it really depends on what area of the brain is impacted. Somebody might present with a hallucination, might be their first sign that something is wrong. It could be motor, it could be memory. Most people think about memory when they think about dementia, but it's not always that. It can be other things. It could be a change in personality. Again, people maybe needing a little bit more help with some of their activities of daily living. So things like driving, preparing or managing meals, managing medications, housekeeping. Sometimes these are some of the earlier signs. Many patients with early cognitive impairments are okay to be alone. They don't need to be supervised 24 hours. They still have enough insight and awareness to maintain safety. There's people around and people checking in. Routines can be really helpful. So setting up reminders and calendars so things are really sort of, made as simple as possible. And early on, this is often a really hard time for patients because there's often still insights. People know that something is off or something is not quite right. This can be quite variable, but often can be very frustrating early on. As people sort of progress through the stages of cognitive impairments, what we often see is more help is needed with the activities of daily living. So you used to be able to leave that person alone and drop off groceries a few times a week, maybe some prepared meals. But now they're really needing a lot more sort of reminders and hands-on assistance. Sort of personal care can sometimes become compromised. People sort of fearful of bathing and falling. Sometimes just less awareness of sort of the importance of those activities. Patients often are becoming more safety concerns and requiring more sort of supervision and support to help maintain safety. This might be something like adding in a life alert early on so somebody has a way of reaching out for help. But this might mean moving in with a child, or a child moving in with you, or some other sort of living arrangement where people can have more around the clock supervision. Changes in personality can occur. These are some of the more difficult things for family members and loved ones to witness when your loved one starts seeming less and less like the loved one you used to know. Sort of not behaving like themselves, perhaps becoming angry or suspicious. This is a really sort of common thing. Repetitive questions or stories, and this is frustrating on both ends. What I see a lot of the times is that family members are trying to correct somebody. They're trying to sort of get their conversation back on track. And you can't do that with cognitive impairments. You often can't sort of jog the memory or remind somebody of, what it is, or remind somebody that they just told us that story 20 minutes ago. It doesn't help. It just causes more frustration on both sides. And the late stages of dementia. So this is a sort of point where somebody is really fully dependent for everything to stay alive, including the ability to eat and drink. Loss of the ability to swallow, or difficulty swallowing, also known as dysphagia, some people like to say, is really sort of key in a lot of the end stages of dementia, and can lead to a lot of distress. We know food is love, and when somebody can't eat, especially when you're trying to care for them, it can be very distressing to understand what's happening and to know what to do about it. People need a lot of hands-on care in the late stages of life. Often bedbound, can't transfer from a bed to a chair, might need a lift to help get them into sort of specialized chairs. Communication is very limited, often lost altogether. Sometimes the ability for one to even hold their trunk up, maintain that sort of trunkal support, the ability to smile. These often go away in the end stages of dementia and can sometimes be some of the hardest things that people witness. Complications such as aspiration pneumonia. So this is pneumonia, infection of the lung caused by particles going down the wrong way. So I just talked about how people have difficulty swallowing or trouble swallowing. This often sort of predisposes one to a higher risk of lung infections. So something that's often seen, often something that can't be avoided. I'll talk a little bit on a slide further down, but one thing that used to be done in the past was to consider placing feeding tubes or sort of surgical tubes for medically administered nutrition. Gastrostomy tubes, PEG tubes are often known as, because the thinking was that if somebody is choking or having trouble swallowing food and nutrition, well, let's just bypass the upper GI tract and give nutrition directly into the stomach. What we find is that sort of putting anything foreign into somebody's body who's already cognitively impaired has its own sort of downsides and risks. But most importantly, it doesn't prevent aspiration. We still have saliva. Our mouths are riddled with bacteria, even with people with the best hygiene out there. And when that bacteria ends up in the wrong places, such as our lungs, it will put us at risk for pneumonia. So you can put nutrition into a PEG tube and administer it that way, but you're not going to be able to prevent the aspiration of oral secretions and its contents, which are really the things that predispose us most to infections or aspiration pneumonias. I talked about the long duration of life expectancies people can have living with dementia and how hard it is to think about when hospice is right. For anybody coming onto hospice, I or one of my medical director colleagues need to review the patient's condition, history, everything we know about them, and make a determination about whether we think they're in their last 6 months of life. somebody can be in the middle stages of dementia for many years, and with really great support, attentive caregivers, great facilities and staffs. It's really amazes me sometimes. We've had some folks on hospice with Alzheimer's, dementia, or similar conditions who have sometimes been with us for several years. And that's because every time a physician reviews their case, we still feel that in our best interest, that person's approaching the end of life. And I wouldn't be surprised if they died in the next 6 months. And some of the things we use to help us determine that are things like the FAST scale. It's the functional assessment staging tool for Alzheimer's disease. So it's basically a score that helps us understand how bad is your Alzheimer's disease. Generally, you're in the end stages. So these are people who are dependent for all their activities of daily living, will often have incontinence as part of their condition. Speech is quite limited, often less than 6 words, very often nonsensical. And we're seeing sequelae of their illness. So they're getting these aspiration pneumonias. They're developing urinary tract infections because you're not up moving around as much. You don't sense when your bladder is full anymore the way you used to. You often see sort of recurrent infections and very severe ones like sepsis. People often develop things like pressure wounds, also known as bed sores, which are quite common. And people can't sense or feel when they need to reposition, or their awareness or sense of pain might be impacted. They're dependent on other people to help move them. So multiple factors that can predispose somebody to sort of pressure wounds. Weight loss is often key. As you can imagine, people aren't swallowing like they used to, or having trouble sort of preparing meals, knowing how to eat and drink. Weight loss is common. And albumin is a nutritional marker or a blood test that we can do. It's a protein in the blood that helps us get a sense of your nutritional status. So when we see that this is really quite low, it's often a sign that nutritional status is as poor as we think. However, each sort of experience with dementia can be quite variable. And I'll often have people reaching out to say, Doc, I was just diagnosed with dementia. I'm recognizing I'm having these concerns. I don't want the life that's ahead of me. I want to come on to hospice now. Like, my goals are to focus on promoting the best quality of life that I have now. And I hear that, it makes total sense. And this is one area where I think that our healthcare system really kind of struggles with sort of making that switch from sort of disease modifying or disease directed care to more sort of comfort and quality of life approach. For many of these patients, that makes sense. Going into the hospital, as I told you, is not always a good thing. It often makes things worse. It makes you more delirious. It often is sort of a repetitive cycle. So people who often sort of want to step away from that and maybe direct their treatment goals in a different way makes a lot of sense. Whether or not we can qualify you to receive hospice care during that time can be a bit more of a challenge. It's not to say that there aren't people with earlier signs of dementia that could still be appropriate for hospice. Many of those patients often have other comorbidities. So you have cognitive impairment, but you also have bad heart failure, bad COPD, maybe bad renal disease. So there may be some ways that some of these folks might receive hospice. But I do struggle when somebody only has something like Alzheimer's disease, because again, it's a condition that can really last for years, and knowing when is the right time can be quite hard. So much that hospice can do to help. One thing is we help provide a lot of education, as we're doing today, but on an individual level, we do this one-on-one with every single patient and family to let them know what's coming, to talk about the things that are expected, and to start thinking about how we manage those. So one recommendation that came out about 15 years ago now, there was a campaign that was done to look at interventions that are often done in healthcare that are either not beneficial or even potentially harmful. And recommendations came out of that. And one of them is that we've now gotten to a place where, as a healthcare system, we no longer recommend surgical feeding tubes in patients with advanced dementia. They don't help, they don't improve the situation. If anything, they only make things worse. What can you do instead? You can continue to offer oral feeding, even if that means people are having difficulty swallowing. There are ways you can adapt the consistency and textures of foods, how feeding is provided, who's assisting the person with that, to really be able to maintain enough intake, and most importantly, to preserve the most important part of nutrition, at least for me, which is the enjoyment of and the pleasure of the taste. Putting a nutritional supplement through a feeding tube doesn't do any of those things. It doesn't prevent the aspiration. It doesn't lead to longer lives, and often leads to more complications. So by focusing on quality of life, you allow people to eat and drink what they can for pleasure. The hospice team is always looking at what else could be happening. Patients with dementia often can't speak. They can't tell us what's happening. So we're looking at what can be precipitating a particular behavior. Is somebody in pain? Many times we see somebody's agitated, they're restless, and they've got a big pressure sore, and nobody's done anything about that. As far as pain goes, we know that these conditions are painful, and it's not that there aren't great providers out there, but if you're not sort of really looking at these things and with a sort of lens to what might be contributing, it's easy to overlook, especially when somebody can't complain to you. Things like constipation are really, really common, and it's something we see very frequently. If somebody's really agitated in the home, and a nurse goes out and determines that they have a fecal impaction, that they haven't been able to pass a stool for many days. So we monitor and help with these things. We're working with caregivers. Part of the most important part of caring for anybody with a cognitive impairment is helping to support the people caring for them. This can be really, really difficult and exhausting work. It can be incredibly meaningful and rewarding work when people feel like they have the support they need to do it well. Things like music therapy can really be really helpful to help sort of jar old memories and really provide some pleasure for our patients. And again, I'm sort of really thinking about caregiver support. Sometimes the caregiver won't tell you, but you look at them, you see the look on their face, you see how they're carrying themselves, and you know that perhaps that person is in need of a break. We do consider some medications to help. Again, if somebody has depression, for example, you might want to consider treating that. We're always thinking about life expectancy, because many treatments take many weeks, if not months, to help sort of become effective. So adding an antidepressant when somebody might have a few weeks or perhaps a month or two left to live might not always be the most important thing. But one thing we do regularly on hospice is deprescribe. By the time patients come onto hospice, sometimes they have medication lists that are 2 or 3 pages long. And what we'll often find is that these are things that were added over time by different clinicians. There's a lot of polypharmacy, meaning just multiple medications that people are taking that might have been beneficial at one point, but that sort of balance between risk and benefit can change. And so we're always looking at, what is this doing for you now? What are the potential downsides of it? Is this still helpful, or is this now maybe contributing to some of the difficulties that you're having? Things like hallucinations and delusions can be treated with medications, but one of the things our team does really well is to help assess them better and determine, how distressing are these? We have many patients who have hallucinations that aren't troubling at all, and sometimes can actually be enjoyable in some way. Patients who are sort of pleasantly confused. So just because somebody's having a delusion or a hallucination doesn't mean you need to throw a drug at them. Is it distressing to them? Is it impacting their relationships? Sometimes I've seen situations where the conversations around those things can actually help relationships to grow and make them stronger. Obviously, if somebody is at risk of harming themselves or in danger as a result of their delusions, those need to be addressed differently. We do use medications on hospice, and some of the more typical ones are the antipsychotic class of medications. So these are all cousins of haloperidol, which many people have heard about. It's the sort of oldest and best understood of the antipsychotic drugs. It's used very commonly in hospice and for many patients with end-stage cognitive impairments. But we use some of the newer drugs as well, things like risperidone, brand name Risperdal, olanzapine, also known as Zyprexa, Seroquel, aripiprazole is also known as Abilify, and these are all very similar sort of antipsychotic medications. So you'll see them used in conditions like schizophrenia, They work on dopamine. They're used for different purposes for patients with cognitive impairments to really help to calm and sort of alleviate some of that agitation that one might be experiencing. Again, Haldol being the most common. We really try to help with non-pharmacological approaches. And we're not just about drugs and pushing morphine and Haldol on people. There are lots of things you can do to really help. So looking at all the non-pharmacological approaches, sleep often becomes a big issue for people. So is it that you're upset that person's not asleep at 9 o'clock every night, but they're getting sufficient sleep? And so does it really matter? How much of it is a convenience issue versus sort of a true lack of sleep? Is there something like anxiety that's underlying the difficulty sleeping that could be addressed? Again, looking at physical activity, things like caffeine or fluids late in the evening that might be having somebody up going to the bathroom. For many of our patients, they haven't changed their mattress in the last 20 years. It might be something that's just really easily overlooked, but are we really doing our best to support good sleep hygiene? Again, things that we can use to help calm before bed, avoiding disruptions in the home like televisions in the bedroom. We're constantly looking at ways that we can help keep our patients with cognitive impairments well over time. So this means encouraging things like flu vaccines and COVID vaccines. Just because you're on hospice doesn't mean that you shouldn't be considering those. They're always your right, but we think they're beneficial because we know patients with cognitive impairments are more prone to serious illness. Looking at things like over-the-counter medications are really important. Trying to discourage people from taking things just because they're not prescribed doesn't mean that that they're not potentially harmful. Again, you want to do your best to avoid any risk factors for delirium. Really encourage people to remain active. And one of the most important things in hospice is really that advanced care planning piece. So, talking about the feeding ahead of time. It will be an emotional reaction, and it's hard to respond from a purely emotional place. So giving people the tools and time and ability to kind of really think through logically, to process and handle their emotions in a way that are ultimately going to help to support them and their loved ones. One thing a note that I had on a prior slide that I failed to mention was specifically around VSED. There was a question that came about voluntary stopping of eating and drinking. In particular, patients who have earlier dementia. I mentioned the patient who said, geez, doc, I see what's coming. This is something that I hope to avoid. What are some of the ways that I could perhaps avoid going down this trajectory? And voluntary stopping of eating and drinking is one of those things that some people have considered as a way of perhaps hastening their death. Now, people are entitled to eat and drink or not eat and drink, whatever they want at any point in life. The challenge with VSED earlier in dementia is that people often still have robust appetites and are often still quite physical. And it's very difficult to deprive the body of one of our most instinctual things, which is to eat and drink. Even people who are able to perhaps fast for long periods of time really struggle with sort of thirst and avoiding fluids when their body can still utilize those things. It's very different in the later stages of dementia, where appetite is often impaired. People are not sort of craving or desiring the same sort of intake that they did before. Many people stop eating and drinking naturally as part of their disease processes. And when those things are starting to happen, it's much easier for will to sort of contribute and for one to say, I'm going to forego all further eating and drinking. But it's much harder to do earlier when your body is still otherwise sort of functioning and your metabolism is still happening. So for anybody to be enrolled on hospice or for me to certify somebody for hospice, they need to have a prognosis of 6 months or less. And that needs to be based on their medical condition. It cannot be based on a decision, for example, to purely stop eating and drinking. If somebody came to me today and said, doc, I'm going to stop eating and drinking, and that's why my prognosis is going to be less than 6 months. At that point, I would not be able to qualify somebody. I would have to say today, you need to have a condition that's a terminal condition that I can say in my best judgment as a physician is likely to kill you in the next 6 months. I can't say that purely based on somebody's sort of desire to consider this process. Now, let's move forward 2 or 3 weeks or a month down the road, and that patient or their family now reaches out and says, our loved one stopped eating and drinking several weeks ago. They've been successful and they're declining. They're in bed now. They're not waking up now. We're now doing all their care. Things are changing. I would evaluate that person at that point in time and would likely qualify them for hospice, because now they are in a condition where I could confidently say that in my best opinion as a physician, I think they're in their last 6 months of life. It's a harder thing to do when it's sort of the start of that decision. It's not to say that I don't support somebody's right to do that, but it's something really important sort of to talk about with your physicians and caregivers. It can be really distressing for a family member when you've told them to not give you anything to eat or drink, and a few days later you're begging for something to drink. So this is, something that really needs to be talked out quite well with everybody involved to really understand what's likely going to happen and the risks and benefits. We're running out of time, and I'm sorry, I said it was going to be 30 minutes, and look at me,
It's really good
55 minutes.
information.
I have 2 more slides and we're going to end. When somebody is admitted to the hospital, or if they come to a facility such as the Gosnell House where I work, we really do things to help sort of prevent delirium. So we encourage people to get up and out of bed if they can. We encourage people to eat and drink if they can. We try not to have people connected to IV poles and catheters and other things that are confusing and sometimes get in the way of your ability to move around. We encourage you to bring their glasses and hearing aids, even if they're valuable. We hear this all the time in the hospital, but those hearing aids cost a few $1,000s each. We don't want them to get lost. Believe me, I understand, and I've seen them get lost. I understand how distressing that is, but in my opinion, I think it's much harder for that person to be there, not being able to participate, engage, listen. It only makes the delirium worse, and to me is not ideal. And again, really kind of keeping people on a routine day-night sleep-wake cycle as much as possible. So I'm just going to end with a sort of resource page. There's so much out there. Hopefully we're an organization that you will continue to go and look to for education and support. It's been really great to spend some time with you talking about such an important topic in our community. But there's so much great stuff out there as well. The Alzheimer's Association has great literature. Go on their website anytime, just tons of resources for patients and families. A lot happening locally. Keep your eye out for events that are happening. Being one of the oldest states in the country, I think this is something that many of us are quite eager to learn about. Somebody recently told me that, remember that when I'm caring for patients with cognitive impairments, that I'm caring for a future me. So this is something that I really care very passionately about, and we all should. It's something that's going to affect all of us in some way, if not us directly, people we love and care about. So I am going to wrap up and say thank you now, and happy to answer more questions.
I'll sneak back on
time.
screen.
Yep.
That was a really great presentation. I see that we may have a couple of questions, but I want to sneak one in too.
Sure.
When we're talking about hospice eligibility and where you guys are doing those important evaluations, one of our messages to the community is always the earlier the better. And it seems like maybe these like dementia and Alzheimer's are easier to bring people on hospice on the earlier side of the 6-month window instead of waiting till the final days. Is that your experience? Do you find that making those referrals and giving people that knowledge and equipping them with that information and getting that plan of care set earlier, you find is easier and happens better? Or as a community of physicians, are we doing that?
I would say that it's really complicated, and I agree. I think starting these conversations early, learning about hospice early, getting the information, it never hurts to make sure that the timing is right.
Okay.
There are very sort of strong regulations around when somebody can come on to hospice. And dementia is actually one of those areas that's considered a risk area for fraud. Because let's think about it, we get paid to care for somebody every single day they're on hospice. And if Medicare was intending that they were going to pay us for about 6 months of care, and now that person's been on service for 2 or 3 years, we have people looking at us to say, did you sort of inappropriately bring this person on early for the billing practices?
Right.
And again, would never be our intention. Our intention is good care, early care, goal concordant care, right? Making sure people are getting the type of care that matches what's most important to them. But the billing and regulations of these things are pretty rigid. And in my experience and patients' experience can be really, really frustrating when it's something that you desire highly. But a physician does not feel comfortable saying that you're in those final 6 months of life.
I know that these particular disease progressions are more with, we're running into them more with older people, but you are also running into them with early onset patients as well, right? And we're hearing that in the insurance world, there are some private insurance agencies expanding that 6-month window a bit for hospice eligibility. Have you run into that at all yet?
Not so much specifically for hospice, but yeah, I think this is a big sort of gap and need, not just here in Maine, but I think nationwide, and for aging people just across the board. Is I think that there is this period where people no longer desire hospitalizations and really sort of aggressive disease-directed therapies, but you're still functional and still enjoying life enough that you're not, sort of in that final phase. And so what then? How do you best sort of support people who are have an increasing need for help, but may not sort of be at that prognostic marker where triggering hospice makes the most sense, at least from our current rules and regulations.
Well, I really appreciated your talking about plan of care and really working that out prior to hospice plan of care, even, as the beginning of your disease progression starts, and working through that and really kind of coming to terms with, what do I want this to look like? So that then you're ready, and then we can adjust it when you come on service with hospice.
And I'm gonna get in trouble if I don't mention the important role of palliative care, which is really sort of come about as a way of helping support people through some of these difficult transitional periods, helping people understand when services like hospice might be appropriate, how do you best utilize sort of their current care and home care and all the other resources that are out there.
And I often think of palliative care more with diseases like cancer. So I don't think of it as often with memory care diseases, but it's also important there.
Absolutely.
Okay.
Any potentially life-threatening illness.
I'll step away from I have so many more questions, but it was just so interesting. But we do have a couple I want to make sure you can answer if we can read them from here. Let's see. Are OTs involved to do an assessment of function and cognition to help identify the dementia diagnosis?
Yes, I mentioned how on one of the slides that you might be sent to a variety of specialists to help do further evaluation, and the input of physical therapists and occupational therapists is often, very, very valuable. To what extent various clinicians might, involve them or not, I think could vary, but absolutely their input is really sort of key, because function again, really is the.
And like nursing staff would give you information as you're doing the evaluation, the same for these types of clinical positions, right?
Absolutely.
Okay. Next, do most patients with dementia sundown as well? If so, why is that?
That's a good question, and I'm not sure. I actually can't answer it maybe as well as I would like, but it's certainly common. It's definitely a classic symptom with Alzheimer's disease that you see that somebody's, kind of getting by throughout the day, and as the day wears on, and certainly as daylight starts to change, that symptoms can manifest. So it is quite common. You can also see it in other types of dementia as well, so it's not specific to Alzheimer's disease. The exact mechanisms about kind of why it happens, I'm not so sure. I might probably composite that just as the brain has less reserve, and so as the day wears on, and some of those, the sort of disruptions in any kind of circadian rhythm, so transitions from day to night, night to day can often be periods that provoke these things.
Next, regarding music therapy in end-stage dementia at Gosnell, is it appropriate to play music if the patient cannot communicate whether that would provide some relaxation and or enjoyment?
Yes, we never want to do anything that the patient may not like. I walked into some rooms and, their country music is blasting, and then the family's like, they hate country music, why are you playing that? So, sometimes it's trial and error. I think that the downsides of music are, doesn't really cause a lot of harm, so I generally feel good about it. I know anecdotally, it definitely seems to change people's energy. Our nurses and aides will often play music when they're in the room providing personal care. But we do a really good job of taking histories from people, and we have these great sheets at the Gosnell House called Getting to Know You. We ask about people's favorite activities, their favorite music, the favorite TV shows that they like. So as much as possible, we're choosing things that are consistent with what we know about them. We know somebody loved classical music or opera, we try to play those things, and it does seem to make a difference. On the other hand, there are situations where noises and other things are clearly provoking somebody or causing agitation, and I do think we do a good job of monitoring that.
It's interesting because one of the other questions I had written down was about nonverbal signs of pain and symptom management, and how does that differ when you're working with someone with a cognitive disease versus any other disease progression that we might see? Are they similar in the way they're observed and we treat and help?
I think they're similar. I think the sort of timeframes might be different. Somebody who's dying of cancer will often reach a point where they're nonverbal or less responsive and unaware, and so we're doing nonverbal assessments all the time. We're doing physical exams. We're monitoring their behavior and activity and making informed decisions about what's likely underlying that. Certainly in the end stages of dementia, it's very similar, but I would say sort of more upstream in dementia, you're doing that more often because somebody just can't articulate. And so you're really being an investigator. You're looking people over. It's similar to having a baby that won't stop crying. You take their clothes off and you look them over from head to toe, and sometimes you find that there's a hair wrapped around their finger, and that's what's causing it. So our nurses and staff do a really great sort of head to toe assessment to see, is there anything I can identify that's potentially sort of driving what I'm seeing?
That's great.
Rather than just throw a medication at somebody.
Yeah, that's so important. We hear that from people a lot out in the field. How does HFM, Hospice of Southern Maine, train staff, volunteers, and caregivers in managing difficult behaviors with activity? I think if I understand that, it would mean when a patient comes on service with us that has Alzheimer's or dementia, right? How do we manage behavioral issues, maybe? Are there activities that, I'm not sure about that, but
I mean,
hopefully, Anne, I'm clarifying that all right.
I mean, our staff and volunteers go through extensive trainings, consisting of educational sessions like this. There's a lot of activities that are sort of electronic that people can sort of review and learn about. A lot of case reviews and collaborations. I mean, we're always, talking as a group together about what worked for one patient, what didn't work. I mean, our staff just have so much experience at this time that, they can pull into their mind a database of so many things that they've tried that have worked for other people. So more sort of formal training and support over time, but a lot of it, comes with experience and sort of shared knowledge. I don't know our volunteers specifically if they have training around this, but I'm sure they do. They're in the homes often. They're frequently engaging with people who may be, compromised in some way or another.
And our staff make it their part of their work to train the caregivers as well, to help them be observant and what they should do and how to respond to certain things. And I think that's really critical, whether the patient's living in a facility where there are, various staff around them. We try to make sure that all of those staff are trained and have the appropriate knowledge for what to look for and what to do, as well as the people at home or people at Gosnell are looking for. Hopefully it's similar kinds of training.
Yeah, absolutely. Support for the family is the most important, I would say. Yeah, really good caregivers will mean that really good care is delivered.
That's right.
Can't do that.
Let's just finish, and certainly we always say this is recorded, so if you have to leave, come back and watch later and we will you'll get answers to these questions. Let's see, can one pay for hospice privately? I believe the answer is yes.
It
if
also,
you,
I mean,
but it's rarely necessary.
yeah, it's rarely necessary that one would need to pay for hospice.
Almost never, right?
Almost never, hospice care is covered by most insurances. I've seen some situations where people have opted out of their hospice benefit. But all insurers have a hospice benefit, that it can become active once you're eligible. So that's really the key, is that your insurance, Medicare is not gonna pay for hospice unless a physician is able to certify terminal illness. And that's regardless of ability to pay. If somebody came to me today to say that they were interested in hospice, they were gonna self-pay for it, they were embarking on VSED today, for example, and I looked at that case and said, this patient's not eligible for hospice. They don't have a terminal condition or a prognosis of less than 6 months. Your desire to pay for it is not gonna sway me one way or the other.
You still have to meet the eligibility.
You still have to meet the
requirement.
eligibility
You
requirements.
couldn't just pay if you weren't eligible.
Exactly, you couldn't just pay if you weren't eligible. The situations where people are sometimes asked to pay is if they're in a unit, for example, like our inpatient unit is sort of the hospital of hospice. It has very strict criteria for being there, similar to when you're in the hospital, you need to have a need and a reason to be in the hospital. If that need has been addressed and you no longer meet the ability or no longer meet the eligibility to be inpatient, but you can't go home for whatever reason, or there might not be a facility to go to, we can no longer bill you at that inpatient level, which means that there is a gap in actually being able to pay for the care that you're receiving. And sometimes we will ask families to help pay for the room and board
Correct.
parts of their care while they're at Gosnell. And we have ways to help assess this, if people can pay, and can self-pay, then we welcome that and we appreciate that. But we also have sort of funds and mechanisms to help to make sure that nobody is deprived of hospice care who could benefit and wants it.
And we like to point that out as a nonprofit hospice agency. We're raising funds in the community. We're working in our community with partners so that we can have funds available to support unique situations that come up. And that would be just one example of many. Yeah. All right, let's see, where are we at? The evidence says that meaningful engagement is an excellent way to manage negative behaviors. Oh, that's connected to the woman who was asking Anne's question earlier.
Yeah, well said.
Yeah, and so I imagine you do engage patients as part of the plan of care because you.
Oh, absolutely, yeah.
In determining appropriate activities. Thank you so much for your time from Brenda, and thank you so much for the excellent presentation. It was really enlightening and helpful from Nancy. And I think that's the end of the list. If you have any other questions, feel free to submit them on the website and we can pass them along to Dr. Moreno and get answers back to you. Look for this presentation shortly to be posted at the Ask the Experts website, which is askhospiceexperts.org, in our library, where you can view all of the sessions that we've done and recorded, as most of them are YouTube video links, so you can see them easily on any device. And thank you so much for joining us. Thank you, Dr. Moreno, for an excellent presentation. Really wonderful. And have a great day, everyone.
Thank you. Have a nice day, everyone.